No. Great. Okay. Well, I am recording now, and I'll just do a little quick introduction, etc. Just let me close this chat box. And has your week been okay?
Oh yeah, it's all good.
Yeah. Great.
No complaints.
Awesome. Okay, so I'll just do a really quick introduction, and you can please correct me, but I want to introduce my team. We're very lucky to have you, Adam, coming to talk with me today about CPR coaching. And I did look up a BIOS, but it's been a little while since you presented at this conference, but they listed you as Director of Research and Development at KidSim Simulation Program at Alberta Children's Hospital, Associate Professor, Department of Pediatrics at the University of Calgary in Canada, that you oversee sim educator faculty development at the national level for the Royal College of Physicians and Surgeons of Canada, chair and co-founder of the Inspire Network, which is international research simulation collaboration focusing on improving outcomes of critically unwell children. And my main sort of motivation for talking to you today, but besides that, was that you also authored, were lead author on the AHA resuscitation education statement, and you've done a lot of work with research on CPR coaching and what is the evidence behind best practice CPR and CPR education. And I also noticed on the Debriefing Academy website that you're living out your hockey related dreams through your children, which I didn't realize. Yeah. Very Canadian. So can you just, for my team at my hospital, are you able to just talk about the CPR coach and what that really looks like in real life?
Yeah, sure. I mean, I think the whole idea of having a CPR coach was driven by research suggesting that a few things. Number one, providers are consistently poor at delivering CPR that's guideline compliant, despite being highly trained, BLS certified, ACLS certified, PALS certified. Number two, within both simulated and real cardiac arrest, healthcare providers are notoriously poor at assessing the quality of CPR by visual means, or even by other means, to be honest, particularly in an emergency room environment. And then number three, our overall perception of the quality of CPR is very poor. So we tend to overestimate the quality of CPR being delivered, both during the event itself and after the event. And of course, if we think that we're doing a good job, there's very little motivation to do better or try harder. So those were sort of like the three key things that sort of pushed us towards developing the CPR coach role and doing some research around that. The role itself was pioneered by Betsy Hunt, who's a pediatric ICU doctor at Johns Hopkins University. And in her institution, they piloted this role, rolled it out within their program, and published a paper called Code ACEs 2, which I believe your team is quite familiar with, showing that the role of the CPR coach, when integrated as part of a quality improvement bundle, demonstrated improvements in overall CPR quality over time. And so when we implemented this role in the CPR coach study, which is a randomized controlled trial done in a simulation-based environment across multiple sites, the CPR coach was tasked with doing 4 key tasks. Number one, coordinating the initiation of CPR. Number two, coordinating provider switches and providing, longitudinal and ongoing real-time feedback on quality of CPR, corrective feedback. Number three, coordinating defibrillation. And then number four, coordinating the task of securing an airway, definitive airway, or intubation. And so those were the 4 key tasks. And the goal of the CPR coach was to ensure high quality CPR, namely adequate depth, adequate rate, excellent recoil. Those 3 things together we would call excellent CPR, and then minimizing the pre, post, and perishock pause duration, which was very tightly tied to coordinating provider switches and reducing time off the chest during defibrillation and during intubation.
So I guess when I was looking at your publications and the Code ACEs trial, what I loved about it partly was that there wasn't one specific magic bullet, but that multiple incremental steps were needed to maintain high quality CPR. But it's very much a confronting reality when we see data that says we're actually pretty pretty average at delivering CPR. We don't give it as well as we think we do. And assessing it accurately can be really challenging. And so one of the things that came up in our conversations about the role of the CPR coach was a little bit about their jurisdiction and integrity, and how a CPR coach can best maintain that they're giving accurate feedback, given that we know there's a lot of challenges with sort of visually assessing CPR. And the team sort of explored using an art line, for example. We're talking about getting Zoll feedback devices, but what do you see as the best practice type picture in this situation?
So one of the key aspects of an effective CPR coach is having a CPR feedback device in the room on the patient that could actually provide objective data on the quality of CPR. And so in the study, we used the Zoll R-Series defibrillator. I have no conflicts, just don't hold shares in Zoll or anything. And then right now, internationally, the PD Rescue Network, which is the international network of ICUs who are using this device and piloting the Zoll, the CPR coach intervention, they use the Zoll as well to collect data and to have real-time feedback. And so what we found was without real-time feedback, the quality of CPR is very poor, and providers have a very poor sense of how they're doing. When you add a CPR feedback device like the Zoll that gives objective real-time data on depth, rate, and recoil, quality of CPR improves to around, if you look at depth only, around 40% of compressions are compliant with depth when you add a CPR feedback device. Then, when you add a coach, who is then using the CPR feedback device to verbally provide data and feedback to the providers, that increases compliance with CPR depth to around 70 to 80%. It almost doubles the degree of compliance. And that's just for depth alone, which is the most difficult metric to achieve when we're looking at CPR quality. So having that device is key. And what the coach does is that person serves as a conduit of information from the device to the provider. Yeah. The reason why that's important is because what we found is that the providers will often do CPR, and some providers keep their head down while they're doing CPR. And so if their head is down, they can't even actually see the screen, which means they're not adapting and adjusting their compressions to the actual quality of CPR. So that was one issue. And so by having a coach there who's verbally coaching, that will allow the providers to keep their head down if they choose to do so. Some providers like to do CPR with their head up, and then they can look at the screen. So that works. Yeah. The other issue is sometimes some teams function where the providers are not necessarily directly across from the screen. I've seen some institutions where the defibrillator is behind the CPR provider, which of course is suboptimal from a human factors point of view, because you can't even see the screen. And so if for some reason programs decide that they need to do that setup, for logistical reasons and just, for access to the patient, maybe because there's an ECMO machine circuit that's being brought in, who knows, they might have very good reasons. The coach is there then able to coach that person because they can't see the screen. The other thing that we found interestingly in interviews is that many providers struggled to do high quality CPR even though there was a device there. And then after a while, they kind of just gave up. Some providers even said, you know what, I didn't really even believe the number because I was trying as hard as I could and it just wasn't giving me good CPR. So I just stopped looking at it. Having a coach there allows that coach to provide specific feedback and strategies to help to optimize CPR. So for example, one of the most common errors that providers make is that they don't allow full release. And because they don't allow full release, they have difficulty achieving adequate depth. And so instead of trying to press really, really hard, all they need to do is allow full release, and then they can get to, the 5 to 6 centimeter target that we're aiming for. And so the machine may not tell them that, but the coach will. And so for those reasons, it's really important to have both the feedback and the coach together as sort of a combined intervention.
Yeah. So, and it sounds to me like almost the CPR coach in some ways adds humanity and validation to the sort of objective data that the machine is giving us, and allows, as well as sort of some granularity and potentially problem solving, why the quality is poor, as opposed to just you're going too slow, you're not going too depth. Would that be fair to say?
For sure, for sure.
Yeah.
I mean, the impact of the machine is dependent upon, number one, the provider looking at the screen,
Yeah.
and number two, the provider reacting to the information that's displayed on the screen. If one of those two things is not happening, then the impact is reduced significantly.
Yeah.
Right? So the coach helps to ensure that both of those things is happening.
This is looking at multiple levels. So one thing that came up was, what makes a good CPR coach? And you've outlined that a little bit in terms of being able to add some granularity and clear feedback. Have you used any particular standardized training to maintain the quality of your CPR coach per se?
We did use training, and I think reflecting back on our study, training was a critical component to ensuring that our coaches were impactful and effective.
Mm-hmm.
We had pretty broad criteria for coaches. Basically, anyone or any profession could be a coach: doctor, nurse, respiratory therapist. Mostly they were nurses, but we had some physicians as well. So I don't think profession matters that much. Obviously, it's nice if they know the guidelines.
Yep.
That goes without saying, I think.
Mm-hmm.
But training them is important because, so what we did was we did training where we trained them to those 4 key tasks that I mentioned before. We used a rapid cycle sort of method where we ran them through very short 1 or 2 minute scenarios where they're given multiple opportunities to practice those 4 tasks.
Yeah.
And then they were given feedback to help fine tune their performance. So the training per coach didn't last that long. Some of them, it was only like 20 or 30 minutes. Others, maybe maximum 45 minutes.
Mm-hmm.
But what we found was that the training helped to streamline their performance and helped to ensure that they were sort of consistently coaching throughout the event. Subsequent to that study, as we tried to roll out this intervention within our own programs, locally at least, there's been a delay in sort of implementing training, but because folks within our institution are aware of the concept, both through the study and reading the literature and just hearing about it through Heart and Stroke and AHA, they've started to do it on their own, both during simulated cardiac arrest events and real cardiac arrest events. And what we found is that they are doing it, but the behaviors that the coaches are exhibiting are not consistent, and they're not they're not executed in a manner which sort of guarantees that they're going to have the greatest impact on CPR quality and patient outcomes. And so as an example, someone might coach and provide feedback on CPR depth. One coach might provide CPR or feedback on CPR depth when it says 4.8 centimeters, but another person might say, "Oh, that's pretty close to 5. We're not going to say anything. I'm going to wait till I get to 4.5." Whereas in training, we trained them to coach to a depth of 5.5, which was halfway between the target of 5 and 6 centimeters, right? So we saw very little variability from that point of view in the study because they were trained. But in untrained coaches, there's quite a bit of variability in terms of what their thresholds are and how frequently they give verbal feedback.
Yeah. And I guess one sort of, you've mentioned some of the challenges in implementation and rollout, that you got that cultural tipping point where there's buy-in to the role, but not necessarily maintenance of the quality. And one challenge I have, because I do sort of statewide training in one of my roles, is that different hospitals have different sets of equipment. They might not have CPR feedback devices. They might be running on sort of life packs and just making their own judgment, or using end-tidal CO2 when the patient's making any, or some of our team mentioned using the outline. If you've got one, sounds great. Do you have any advice for places that don't have a ZOL in terms of improving quality of CPR feedback?
I mean, I think if they don't have real-time feedback, but they have devices that collect CPR quality, I think the first thing would be to say is to start looking at that data so you have a sense of how you're doing. Because one of the biggest driving factors within our institution and others that have implemented this program is knowing exactly what the quality is as a baseline. And when you know that you're doing a poor job, there's more motivation to get better. So by all means, I think that's like one of the most important things, is starting to look at objective data and say, listen, where are we struggling and how can we start to address this problem? For those places that don't have the feedback device, I mean, I think looking at other measures of CPR quality are important. The more that you have, the more objective measures that you have, the better. Art line tracing is great. End-tidal CO2 is great, and that in those two in conjunction with visual assessment, would probably do a reasonable job. Of course, it's really hard to know what the thresholds are, and those will vary depending on your patient size and age. So,
yeah.
So the data from the CPR feedback machine is also just another data point. It's just one of many data points.
Yeah. I saw in one of the Johns Hopkins sort of demonstration videos they have for their staff, they turn on a metronome specifically as well, which I quite liked within the room. So I think
I think the metronome helps with rate. But what we found in the series of studies that we've done over the last 10 years is that rate is the one metric, CPR metric, that people comply with the easiest.
Really?
That the easiest time complying with.
Yeah.
And so you'll see that the compliance rates with rate are quite high once you get a feedback device in, or a metronome, upwards of 80%. Depth is where people really struggle. Depth, recoil, and then working towards reducing the time off the chest. But rate is usually, the compliance rate with rate is usually quite high.
Yeah. Oh, brilliant. Great. Well, I know you're a busy man, so I think we might wrap it up there if that's okay. I just wanted to really thank you for your time. I'm going to share this with my registrars and nurses, and we'll continue to discuss how we can get better in our local hospital. But I know you're a very busy man, so I'm very grateful.
Yeah, no, happy to do it, and good luck to you, Ben, and the rest of your team in implementing this intervention. Good luck.
Great. Thanks a lot.